Great. All right. Well, welcome everybody. We're happy to have you here at the last session of the semester for the latest in public health research series. And we're delighted to have Laura Balzer with us today. She's an associate professor in the biostatistics department here at the school, and she's going to be talking about some of her most recent research. I've lost the title now, but you'll have to remind us of the title when you get started. But thanks so much, Laura, for being here.
Great. Thank you all so much for being here today. Welcome to wherever you're joining us. Can you see my slides? Wonderful. So I had promised to talk focusing on machine learning, but decided to pivot to talk about a bit larger of some of our contributions in biostatistics and the School of Public Health, focusing on community engaged and community-led research to end the HIV epidemic. But I do promise I will get to how we can use machine learning to improve community health. This is joint work with a lot of people, but in particular, I'd like to acknowledge my colleagues that are part of the search consortium. So one of the reasons that I decided to pivot my focus a little bit was yesterday, December 1st, was World AIDS Day. And it was actually the first time that I know of that World AIDS Day was not acknowledged by our federal administration. As many of us know, there's been massive changes to federal policy as well as funding. Yesterday, this UNAIDS report came out about overcoming disruption and how we can transform the AIDS response. Here's a quotation from our executive director about the funding crisis, and really reminding us that behind every data point, there are people who are now being missed for screening, cut off from prevention support, left without services or care. And we really need to work together to figure out a path forward. And the theme of the IAS, which is the big International AIDS Society conference held every July, is how can we rethink, rebuild, and rise up? And so what I want to do now is go back in time about 10 or 15 years ago and talk about some lessons learned earlier in the HIV epidemic and how we can use those to move forward. So let's take a flashback to the HIV epidemic in 2010. So this was 15 years ago. At the time, antiretroviral therapy, or ART, had been proven to be highly efficacious and effective treatment for HIV. Nonetheless, the World Health Organization, or WHO guidelines, said we should delay initiation of ART for persons with HIV until they got really sick. So until their CD4 count dropped below a certain level. And this is illustrated in our schematic on the right-hand side here on the bottom. The guidelines essentially said we can allow for health deterioration and shouldn't start people earlier on treatment. Nonetheless, there was early data that suggested that early ART initiation had lots of benefits. In particular, it protected and promoted the health of the person with HIV. So it kept them in this green zone. Additionally, there was evidence that it would reduce onward HIV transmission. So either from a mother to their child, or from a person with HIV to their sexual partner. But this was against World Health guidelines at the time. So one of the questions that came up is, how do we change this HIV treatment paradigm? In particular, how do we design a universal HIV test and treat strategy, which I'll abbreviate UTT? Universal HIV test and treat is a strategy to go out and engage with entire communities to test everyone for HIV. And for those persons with HIV, get them immediately started or restarted on ART. So it's a strategy or package for both early diagnosis as well as early treatment. Other key questions were, how do we actually deliver such a strategy at scale? So at a population level. This is sometimes considered to be an implementation science question. How do we go out and reach entire communities for both testing and screening for HIV, but also treatment, including same-day start? And then finally, and maybe most relevant as my role as a biostatistician, how do we rigorously evaluate the effects of this strategy? In particular, how can we generate high-quality evidence to change both guidelines and to inform policy. And these questions led to the development of the SEARCH Consortium. SEARCH stands for Sustainable East Africa Research in Community Health. It's a multinational, multidisciplinary collaboration between University of California, San Francisco, University of California, Berkeley, Infectious Disease Research Collaboration, or IDRC, in Uganda, and the Kenya Medical Research Institute, or KEMRI, in Kenya. Our goal is to evaluate bold interventions, so interventions that are pushing the boundaries on how we screen, treat, and care for patients, with our goal of improving health and informing policy. Our website is linked here. And so the development of this consortium led to the SEARCH Universal HIV Test and Treat trial. This was a two-arm cluster randomized trial of over 320,000 participants who were in 32 communities in rural Kenya and Uganda. This trial was conducted from 2013 to 2017. And our big picture here is our intervention. We used a community-based and multi-disease and patient-centered approach to universal test and treat. And we contrasted this with an active control, which was the enhanced standard of care. So this was a randomized trial. So we randomized 32 communities, 10 in Uganda East, 10 in Uganda West, and 12 in Lake Victoria region of Kenya. Each of these communities had about 10,000 persons, so we enrolled over 320,000 participants. So let's go into more detail what the arms of this trial were. In our intervention arm, we offered multi-disease testing through community-based health fairs that occurred annually, baseline and annually. Some pictures of these health fairs are shown on the right-hand side. The top is a health fair in a rural farming area in Uganda, and the bottom a fishing village in Kenya. These were 2-week out-of-facility events, so bringing screening and linkage to care directly into communities. We screened and offered services for HIV, hypertension, diabetes, malaria, deworming for children, and so forth. So these were not HIV testing campaigns, but instead we really tried to get entire communities to come out and participate in their health and well-being. And so if persons tested positive for any of those conditions, we immediately linked them to care so they could meet their doctor right there in the health tents. And for treatment, it was universal eligibility. So instead of waiting for the person to get very sick, for HIV, for example, we included same-day start of treatment, as well as a warm handoff to the doctors. In the intervention arm, we had care delivery through what we call the patient-centered and streamlined care model. This is really an approach to go out and treat the person and care for the person, as opposed to just one disease or two. And it has things like being, nice and friendly to your patients, asking them how they're doing, having a welcoming environment, as opposed to what's sometimes the standard of care in HIV, which is pretty stigmatizing and pretty hard on patients to immediately essentially accuse them for why they might have become acquired HIV and I might be achieving viral suppression. So this was a chronic care model, again, recognizing HIV as a chronic disease, again, rapid start of treatment, counseling based on viral load results, and so forth. And we contrasted this with an active control. So it was a highly active control because we use the same mechanism for multi-disease testing at baseline. The treatment in the control arm followed country guidelines, which actually changed within 1 year to near universal eligibility for ART. And the care followed the country standard. So I know that's a lot of information, so let me break it down one more time in a different schematic. So here's a different schematic of the SEARCH trial design. Randomized 32 communities. So our unit of independence, our sample size, you can think of it in terms of our N for statistics, is 32 here, even though we had about 10,000 persons per community. At baseline in both arms, we offered community-based and multi-disease testing, hypertension, diabetes, as well as HIV. And for people that didn't come to those health campaigns, we also offer the same services at a location of their choice, usually their home. So what differed? What differed between our two arms was who was treated for HIV and how they were treated. So our intervention arm, all persons with with HIV were immediately eligible to start or restart treatment, and we delivered it through a patient-centered and streamlined care model. Here's a big picture schematic on the bottom here, summarizing what I just said: 16 intervention communities versus 16 active control communities, baseline testing in both arms, different eligibility for treatment and for care. And then at year 3, which is end line of the trial, we repeated our population-based testing for both health outcomes as well as socioeconomic outcomes. So what did we find? So we found that the search community health approach to universal test and treat increased population level HIV viral suppression. So this is the proportion of all people with HIV who are suppressing viral application from a baseline of 42%. So less than half the people with HIV were controlling it at baseline, to 79% in our intervention arm, as compared to 68% in our control arm, vastly exceeding what were the UNA guidelines at the time. We also found a lot of impact on other community health outcomes as well as socioeconomic outcomes. So really highlighting this community-based, community-led, multi-disease approach to screening as well as treatment. We found about a 50% reduction in mother-to-child transmission of HIV, a significant reduction in mortality among persons with HIV, so reducing it by 28%. Reductions in HIV-associated active tuberculosis or death, so a whopping 59% relative reduction. And we also had improvements of control for non-communicable diseases, such as hypertension and diabetes. So overall, increased the relative proportion of persons with either hypertension or diabetes who were controlling those diseases by 26%. Also, significant impacts at a population level on mortality. So we significantly reduced mortality among persons with hypertension, so not even people with HIV. And as I said, this community-based approach and multi-disease approach had impacts beyond just health. So we significantly improved economic outcomes among adults with HIV. So the proportion with any reporting any work was significantly higher overall for persons with HIV, and especially those with higher CD4 counts. We also had improvements among education for children in households where there's at least one member with HIV. So significant improvements in children completing primary and some secondary school education. We did not find a significant difference in HIV incidence between arms, but we did see a significant reduction in HIV incidence over time within the intervention arm. So to recap, this was a large-scale trial to evaluate strategies for both early screening and for early treatment for HIV and beyond. We rigorously evaluated population-level effects and found significant reductions in HIV incidence over time, significant improvements in community health between arms, including reductions in mortality at a population level, mother-to-child transmission of HIV, improvements in control for hypertension, diabetes, other NCDs, as well as reductions in tuberculosis. We also found that our approach improved socioeconomic outcomes, so more adults working, more children completing education. And the results from the SEARCH trial and other universal test and treat trials really went on to shift the paradigm for both HIV treatment and care. So universal eligibility for ART is now the standard, and patient-centered care is now the standard approach. So now what I want to do is I want to take some of the lessons that we learned from SEARCH as well as beyond SEARCH. So this table summarizes the 15 or so other trials for which I have served as the primary statistician over the last 10 to 15 years. And so for each, we have the primary goal, who the trial population was, and the study design, as well as the primary citation. So these are all working within the SEARCH consortium, include things like preventing tuberculosis in the overall community, um, as well as focusing those on with people with HIV, optimizing HIV care for persons with HIV, including populations that might have more trouble accessing care or staying in care, or just might need more support. So persons that are highly mobile, have heavy alcohol use, um, younger persons have different needs than older persons, pregnant and postpartum women experiences different challenges. Also, several studies there how we could optimize HIV prevention for persons that have current or anticipated HIV risk, both in facility-based interventions, community-based interventions, um, and women working in high-risk venues, so venues where sex work is common, or alcohol-serving venues. And finally, moving into, again, this is not just an HIV story. We also want to improve community health, optimize hypertension screening and control, again, in the overall population, as well as persons with HIV. And so these studies spanned things like district level CRTs, which is community randomized trials, smaller individually randomized trials, pre-post pilots, and so forth. So what are the lessons learned over these years? First and foremost, community-engaged and co-led research is key. We would not have these successes in search. We would not have saved lives, improved community health, prevented HIV, seen all of the socioeconomic outcomes if we had tried to do this on their own. This is really a equal playing field partnership of multi-disease, multinational and multidisciplinary collaboration. I cannot thank my colleagues enough. Um, it's really been my life work to work with this team and so many that aren't pictured here. But I really, really do stress the importance of co-led strategies and co-led research. The second lesson is if you want to do these trials to rigorously inform treatment guidelines and influence policy, I recommend learning to love cluster randomized trials. So in cluster randomized trials like SEARCH, we randomize groups of participants, such as communities or clinics, to the intervention and comparator condition. Cluster randomized trials are integral to evaluating or optimizing strategies that are either deployed at the group level or induce changes at the group level. So you can think of several health strategies that want to expand service delivery into the community. This can be done with health campaigns or using community health workers, or just setting up services at things like bars or so forth. Other ones could be changing the care model or care delivery of the health system overall. So this could be implementing the patient-centered care model, doing things like expanding services through telehealth and so forth. Cluster randomized trials are beautiful because they preserve that rigor of randomization. So we're still randomizing clusters to intervention or control. So at the end of the day, I get to use the word effect. They also allow us to assess real-world effectiveness. So they're inherently pragmatic trials. So we're learning both the effectiveness as well as the implementation at scale. These cluster randomized trials also provide an opportunity to amplify impact because we get the direct as well as the indirect benefits of our intervention or our strategy to all cluster members, including those who might not directly uptake the intervention or be involved with it. So you can think about just doing population-based or community-wide testing for HIV, reduces stigma around knowing your status, and overall promotes engagement in health services, even among people who don't directly test for HIV. Or more directly, just reducing the overall viral load in the community, reduces the potential for acquiring HIV. And I also think these cluster randomized trials can really help inform policy decisions because they help inform Ministry of Health and other implementing partners. What would this look like if I rolled it out to my community at scale? But of course, they have challenges, and I still have a job. So the first challenge is clustering. So we have to deal with the dependence of participants and persons within our clusters and communities. And this often translates to far fewer independent units than if we had done a individually randomized trial. Concretely, in search, we had roughly 150,000 adults, which is in this context, age 15 years and older, but our independent unit. So at the end of the day, what I run my t-distribution on is based on 32 communities. And again, this is not unusual. Most cluster randomized trials randomize fewer than 40 units. And so this puts an increased risk of both type 1 and type 2 errors. As I said, cluster randomized trials are inherently pragmatic. They are not tightly controlled drug trials. They're much more implementation trials. One of the consequences of that is that we have a lot more missing data. One review found that nearly all, 93% of cluster randomized trials have missing outcomes. And we really need to account for missing data or censored data to avoid meaningful bias and misleading inference. So this is illustrated slightly in this small directed acyclic graph here, where we have a randomized trial arm, but we have things both at baseline as well as post-baseline. So for example, being in care, that influence both health outcomes and their measurement. And so we need to appropriately account for both baseline and time frame factors that influence missing data or censored data, as well as those health outcomes. And so one solution that we came up for this for cluster randomized trials is known as two-stage TMLE. If you haven't heard of TMLE yet, I will circle back to it at the end of the talk, but you can think of it as one of the state-of-the-art methods for causal inference. And so how does two-stage TMLE work for cluster randomized trials? So what we do in stage 1 is we take each cluster or community in turn. And within that cluster or community, we think really hard about what assumptions are needed to adjust for missing or censoring data. So formally, this can be thinking about what are the identification assumptions that allow us to say, okay, within all these values of these baseline and time varying covariates, persons who we got to measure or test are going to be representative persons who are missed. It's a bit more complicated, but that's it in a nutshell. So within each cluster or community separately, we first identify, so we write down what we want to learn, and then we estimate that endpoint, accounting for missingness or censoring at the individual level. Then in stage 2, we use those endpoint estimates to evaluate effectiveness of the cluster level intervention or the community level intervention with maximum precision or maximum efficiency. So here's a schematic of our two-stage TMLE for cluster randomized trials. So here in this box is my trial. Each of the big circles you can think of as our intervention in blue and standard of care in red. We take each in turn. We stratify on that cluster. We identify and estimate. So this will be an individual level TMLE. If you prefer alternative approaches, you can do something like inverse weighting or G-computation, but to really flexibly control and adjust for baseline and time varying factors that influence both health outcomes as well as their measurement. And then we move to stage 2, where we use those estimates, denoted YC hat here. And we run a cluster level TMLE to maximize empirical efficiency. So to get us the most precision for evaluating effectiveness. And we can incorporate weights and so forth to target different parameters or different estimates. So that's the first lesson is second lesson, learn to love cluster randomized trials, and then implement appropriate analyses to adjust for challenges inherent in those cluster randomized trials, including missing and censored data, as well as few independent units. In order to do this adjustment for missing data, the other lesson then is we need to really know something about persons who are missing. Again, persons whose outcomes are measured are often different meaningfully from those who are missed. These can severely bias our estimates of effectiveness. This is illustrated in the graphic on the right-hand side. So this was a sub-study of search to look at the effectiveness on the incidence of latent TB infection, which is a proxy of population-level transmission. And so if you start on the rightmost, the unadjusted effect estimator, which is excluded anyone with missing data, gave this erroneous conclusion that didn't make any sense. It actually relied on assumptions known to be false given the sampling scheme in the sub-study. Inverse weighting slightly lowered estimates, but we could see it was very, very imprecise here. But implementing our fully two-stage TMLE approach suggested the search intervention led to a 27% reduction in the relative risk of latent TB infection. In other words, using these advanced methods reverse the trial conclusions for this very important secondary endpoint. Big picture-wise, TMLE offers a robust and efficient approach, but we can only do this adjustment with TMLE, inverse weighting, standardization, your favorite approach, if we know something about who we're missing. So this requires that we measure something about the entire target population. This could be done, for example, in search. We've done this with community-wide rapid census that we've either conducted as a research team, or most recently, we're leveraging the existing census by community health workers. Another huge lesson is that measurement or testing impacts health. So this might seem obvious, but it's really important statistically and to evaluate and generate these evidence at a population level. So the first step in any treatment or prevention is knowing your status. Am I currently at risk for HIV? Do I currently have HIV, for example? In the first search trial, we conducted this population-level, community-based HIV testing in both arms. You can show in the right here from our New England Journal paper, before we did any testing, about 57 to 58% of residents reported ever testing for HIV. And then after our baseline push, or our baseline activities, it was 90% or higher in both arms. So this is a huge intervention on health and well-being. We did this to establish an HIV negative cohort for prospective follow-up. The impact was an active control. And so modeling estimates suggested that if we had done a true control without these activities, we would have had a 27 to 45% reduction in HIV incidence between arms. So what are some alternatives? We really want to have a well-established cohort to measure our intervention effects. How do we do this? One approach we recently undertook is only doing population-wide testing at endline in the control arm. So essentially have a completely hands-off control arm for majority of the trial and just do testing at the end. Other approaches we have taken in other studies are to rely fully on Ministry of Health existing data in the control arm. This also has some limitations. Or in other studies, we relied fully on existing Ministry of Health data in both trial arms. Continue on this theme about how measurement or testing impacts our health. A lot of the strategies that we evaluate aim to improve health screening of the target population and then improve health outcomes among those screened. This is illustrated in another directed acyclic graph here, where we see that we have some cluster and individual baseline characteristics. These influence whether or not you, in this case, screen for HIV risk, as well as your underlying, possibly under-observed risk status. Our cluster level intervention, as I said, has two aims. First, to increase risk screening and to improve outcomes among those screened. So we have a direct effect of the intervention on increasing prevention use in this case, as well as an indirect effect through screening. And screening establishes your observed risk status, and therefore you can start things like biomedical HIV prevention. All to say, this creates a really fun multi-level mediation missing data problem, which is a mouthful to say and a mouthful to actually evaluate. And we've shown recently that standard methods that adjust for differences between persons screened versus not screened fail. And they fail because we're blocking this indirect effect, which is really important, on increasing who's screened, who knows their status. And this will bias overall effectiveness estimates towards the null. And so what is our solution here? I'm very happy to highlight one of my rising stars, PhD student, Joy Nakato, who is doing dissertation work specifically on answering this question: how can we rigorously evaluate effectiveness when measurement or screening or testing mediates the effective interest. And I hope Joy might be on and be able to answer questions towards the end of the talk, but there's the QR code to the archive paper as well as the website if you're interested. Going back to lessons learned, evaluating intervention packages is actually quite hard. Um, Often the packages that we study are multi-component interventions, and they're multi-component because they're designed to address multiple barriers to health at multiple levels. And they also acknowledge the unique and dynamic needs of our participants. So on the right-hand side is a summary of our youth trial or intervention, focusing on improving health outcomes among 15 to 24-year-olds with HIV. And you can see the barriers that we identified with our community partners, as well as the interventions both at the individual level, such as life stage assessments. So when the client comes in for their visit, you don't immediately ask them if they're on treatment, if they're biosuppressed, instead you ask them how they're doing, ask about life events. If we recall being that young, a lot of things happen between 15 and 24 years old, and just establishing a relationship between the doctor and the patient goes a very long way. Often we also change things to how care is delivered, so alternative access choice, so where and when you get care delivered, so changes the care delivery model, rapid viral load feedback. So this is giving rapid testing for HIV viral load and giving tests back right away, so reinforcing behaviors, as well as offered e-collaboratives for providers. These are mostly in very rural, isolated clinics, so they had a secure WhatsApp communication to talk about different challenges and particularly challenging patients. So multi-component interventions make a lot of sense, but statistically they're pretty challenging because everyone wants to know what component of the intervention had the biggest impact. If you want to roll out the strategy at a policy level or country level, which one of these interventions do I really need to focus on? We know resources are limited. So I have written a sentence like this or something very similar in many, many of my papers, which really, again, highlights this limitation, but also the importance of qualitative studies. Some alternative study designs we can consider are factorial trials or fractional factorial trials. These also have some logistic and statistical challenges. We can think about undertaking formal mediation analyses to try to figure out the pathways of intervention action as well. The other lesson learned is that the standard of care may change. So, for example, in search, the guidelines for treating for HIV shifted to near universal eligibility within 1 year of the trial launching. We embraced this change in the control arm, and actually we provided more staff and support in the control clinics for them to get everyone on ART according to these new guidelines. These changing guidelines are fantastic for patients and communities, and also arguably made for a more interpretable effect. So a more relevant counterfactual comparison of what is the effect of the search intervention versus the current standard of care as opposed to an old standard of care. But as you might imagine, it was not so great for statistical power. And of course, we experience a lot of other system-wide shocks in these large policy-changing trials. So in search IPT, IPT stands for isoniazid preventative therapy. It's prevention for tuberculosis, in this case, focusing among persons with HIV. In this study or trial, we had things like drug stockouts. So there was no drug, so it's hard to evaluate uptake of a drug if there's no drug in country. Then there was an external push tied to financial contingency, which pretty much says you need to put everyone on this drug or we withhold your money. And then we also had COVID-19. Similar challenges also occurred in the search use study, including the rollout of new and better drugs in the middle of the trial. Again, in that case, fantastic for patients and communities, but makes the stats more challenging and fun. And as I started my talk with, there have, of course, been massive changes to foreign aid and grants since January 2025. So a couple other things to highlight in lessons learned. For HIV prevention trials or other preventative trials, I think it's really important to recognize that both risk and choice are dynamic. So will experience risk at different times. They also might want to choose different prevention modalities at different times. So maybe they're on oral pre-exposure prophylaxis and switch to injectable, or maybe they're not at anything because they're not at risk at the time. Furthermore, for prevention trials, the population of our prevention effort changes over time. Again, because risk changes over time. I can spend a lot of time talking about different randomization strategies. So I've done a lot of work on pair matching in cluster randomized trials. So this is the idea that you go out and you pair together, for example, communities based on covariates of variables that are going to be predictive or prognostic of the primary endpoint, and you randomize within those pairs. That improves statistical power, also improves interpretation because you're guaranteeing balance on certain factors, and also improves community buy-in. So we actually have done a lot of these randomization events with community leaders in the field where we have representatives from each community come together at an event. They put their hand into a hat and pull out intervention or control, which is really good for understanding the study as well as participation. Also, recent work to show that in cluster randomized trials, the randomized unit isn't necessarily the independent unit. Could spend a lot of time talking about causal estimands. So whether or not we want to target the effect for the sample that's enrolled or larger population effects, how we want to weight individuals or clusters. And last but not least, costing is really crucial. I personally do not do costing, but I know that it's essential for our implementing partners to really understand, okay, we've shown this works, we've shown the effects, but what is it going to cost? How can we roll this out in a way that is sustainable? And with my last few minutes, I actually want to pivot back to what I promised to talk about, which is causal inference and machine learning. So let's talk a little bit about how we learn effects with messy real-world data. I focused a lot on cluster randomized trials where we have randomization, which is fantastic, but we also have few independent units and lots of differential censoring or missingness, or at least the potential for that. And more generally, beyond trials, we have things like confounding, we have mediation, we have messy DAGs that look something like this. And so for fun here, I wanted to take a flashback to the search stats team in 2010. So this is when I was a first year PhD student here at Berkeley with my two advisors here, Dr. Meyer Peterson and Dr. Mark Vendelon, who I think I sneakily took that picture as a PhD student to illustrate Mark's brilliance and also unique style for writing on the board. So how did we think about learning these effects with messy real-world data? So one framework for causal inference that's been developed and pioneered at Berkeley is known as the causal roadmap. It has its underpinning of the scientific method, often attributed to Descartes. And it's a systematic framework from going first from our research question. So what do I actually really want to learn from these data, from the trial that's been about to conduct or already has been conducted, or these observational studies, or this policy change? Specifying a causal model, I showed some directed acyclic graphs to really represent the data generating process and assumptions. Step 3, we specify our causal estimand. So this lets us play the game of what would have happened if conditions changed. So if we had changed the way in which the exposure was rolled out, had prevented all censoring. In step 4, we move back to the usual world of statistics and talk about the observed data, so the data that you'll learn into R or Stata, and the statistical model. Step 5, we go through identification, which I hinted at it before, which is really asking us to evaluate transparently, and again, with our community partners, what assumptions are needed and are reasonable to translate this wished-for causal parameter into something I can actually estimate. For estimation, I've highlighted the role of TMLE, which I'll go into next. And then finally, we don't want to forget about interpretation, so appropriately interpreting our results in line with prior steps of the roadmap. So the roadmap, again, is one of the frameworks for causal inference. There's others out there like target trial framework. We all tried to get the same place, but I found it incredibly helpful in all of my research to work formally through this roadmap. So what is TMLE? TMLE stands for several different things. Each one is a generalization of the prior. So first developed as targeted maximum likelihood estimation, that then got generalized to targeted minimum loss-based estimation, and now is referred to as targeted machine learning estimation. What is it? It's an algorithm that incorporates updating of our initial estimates of the expected outcome that uses information in the propensity score. So the propensity score could either be the propensity or the probability of being exposed, given the adjustment covariates, or it might be the propensity of being measured or not censored, given those adjustment covariates. And what is this updating or targeting? It focuses our estimation efforts to where it matters most for our question at hand. So we get the best bias variance trade-off for our causal parameter of interest, or for the effect that we really want to learn. It also gives us back accurate quantification of uncertainty under reasonable conditions. So it integrates all of these recent cited advances in machine learning with formal theory. So we get back 95% confidence intervals and hypothesis tests that we can trust. And so why would we want to use TMLE or over other methods that might be more familiar? So other common methods for causal inference are singly robust. So if you do G computation or G-comp or standardization, that means you have to do a really good job estimating the expected outcome. Conversely, if you want to do something like inverse probability of treatment or inverse probability of censoring weighting, we must do a really good job estimating the propensity score. TMLE is a double robust point estimate, so you have two chances to get the right answer. So you can either get the outcome regression or the expected outcome correct or the propensity score, and you'll have the right answer. It's actually a bit better than that, but I won't get to the formalism now. TMLE is also an efficient estimator. So if we do well on estimating both the expected outcome and the propensity score, we'll have the most precision and the most power, so the tightest confidence intervals. And finally, TMLE harnesses machine learning, in particular an algorithm developed here at Berkeley known as superlearner, which is an ensemble method that combines predictions from multiple machine learning algorithms. And this is really important. So this really lets us relax and get rid of all of those parametric modeling assumptions that we, or at least I didn't generally feel good about specifying. And so we minimize those assumptions and minimize bias due to regression model misspecification. So if you want to learn more about causal inference and the causal roadmap, as well as TMLE, I'm teaching the spring course, Intro to Causal Inference, online. And here's a schematic of an alternate presentation of the causal roadmap. We can see that things quickly get a bit more complicated with these real-world studies. And my final point here, again, the most important lesson learned over the past 15 years or so, working to design, implement, and analyze, I think it's 16 randomized trials now, is that community-engaged and co-led research is key. I really can't thank and acknowledge my colleagues listed here from around the world. Also want to thank and acknowledge our study participants and communities, the Republic of Kenya Ministry of Health, the Republic of Uganda Ministry of Health, the co-PIs of SEARCH, Doctors Diane Havler, Moses Kamya, and Maya Peterson. Again, my many collaborators from around the world, our funders from the NIH and beyond, as well as Gilead and V for drug donation, and many others on the team and those who serve as an advisory capacity. And I will stop there. Thank you.
Great. Thank you so much, Laura. That was a fantastic presentation. I learned so much. Would people want to chime in with questions, either add questions in the chat or feel free to unmute and ask a question? We have a quiet group today. Lots of clapping, though. That's great.
Yeah, sorry, I know that was like a lot of information from a whole bunch of different perspectives, but hopefully gave a sense of really, as a biostatistician, how we can contribute to this community-based, community-led research and change global policy. And again, hopefully it inspired some thinking about how we can take the lessons learned and really figure out how to move forward with the recent
Yeah,
changes in federal policy and global policy.
yeah, definitely. It's so important.
Maybe I can call out Joy. Joy, do you want to say hi and maybe share a couple of words on your work in this area?
Sure, Laura. Hi, everyone. Thanks for the opportunity. And I mean, I also rarely sit in to listen to Laura do full-blown out presentations. I'm always also learning a lot from the incredible work that has been done over the years through the such collaboration. Yeah, like she said, my dissertation is mainly about estimating effects in an efficient way in cluster randomized trials where we have complex missingness mediation mechanisms. Um, and particularly, my work was inspired by a sub-study within the such trial that was looking at an intervention at alcohol drinking venues that was supposed to improve uptake of HIV by medical prevention. Um, but the pitfall was that individuals need to be screened before they are eligible to uptake PrEP, and so that mechanism from the intervention to uptake of PrEP is mediated by screening, and our usual approaches break down, and we have illustrated those in simulations in our preprint and a new script that is currently under review. Hopefully will be accepted. But yeah, it's been exciting to see how we can solve problems from a statistical lens that are inspired by real world studies, real world problems. So solving problems that are actually relevant and contributing to advancing health globally. Yeah, I'm happy to answer any questions concerning my work if anybody has, or chat more. Thanks, Laura. Thanks, everyone.
Thanks, Joy.
Thank
Um,
you. There's a question from Jay. Are people adopting these new statistical methods in global health, or have they not gone widespread, or what do you think about that?
Great question. Um, Multi-part answer. So I do think methods for causal inference are becoming more and more the norm, especially relative to 15 years ago when I was a PhD student. Um, I've actually had a lot easier time publishing these advanced statistical methods or applying them in top tier journals like things like New England Journal of Medicine, JAMA, the Lancet series, and so forth, as opposed to getting them published in things like epidemiology or AJE. So I think that there's a recognition among our global partners that while they might not understand the exact method going into it, they understand the reasons for it, are willing and open to use things that are going to robustly address things like differential missingness or censoring or just some of the challenges that I um, put on here. And I also think I know Jen and Alan and others on the call and I have really worked hard to try to get these tools into people's hands. So we're not developing methods just for the sake of methods, as Joy said. Instead, we really, really want to have the best evaluations of effectiveness. That does develop new methods, but also dissemination and translation is key. Having buy-in from our community partners and from our larger research team is also key. And I'm hoping they'll go more widespread. Maybe to answer your question, Jay. Thanks.
Great. Well, thank you so much again. We're just about at time, but we really appreciate your talk and thank you so much for sharing your work with us. Hope everyone has a great rest of the day. Yeah, thank you so much.
Thank you so much for having me.
Yeah, take care. Bye bye, everyone.